ICS Costing Hub. My name's Emma Min. I'm the Senior Finance Benchmarking and Reporting Manager at the Acute Trust in the system, MSc FT. And Rachel's also going to be speaking a little bit later after me, and she's one of our system costing managers at the ICB. We're going to take you through how the Costing Hub came about, some of our achievements and the challenges we faced, and some of the projects we've been involved in, and mainly what we still want to do, because it's still a work in progress and still quite a long way to go. So if I give you a little bit of history first, our ICS is relatively unique in that we've only got one acute trust service in the area. Prior to 2020, there were 3 acute trusts, and we merged in 2020, just as COVID started, so that was all good fun as well, to form Mid and South Essex Foundation Trust. That brought with it lots of challenges, and the newly formed costing and benchmarking team set about navigating kind of the new landscape, working out how to bring those 3 costing models into one, and also supporting the newly merged organisation in everything that they were trying to do, and providing them with information and advice about how to kind of merge all those services, and change the way everything was running. So we began with taking a look at our SWOT analysis, our strengths, weaknesses, opportunities and threats. I won't go through the whole slide because there's a lot there, but we'll share the pack later. This helped us understand kind of our risks, what we thought we were good at, what we needed to look at, what we needed to take forward, and sort of developed an overall vision and a plan for our service. Lost the button. So that led to us putting together our vision, which was basically we wanted to make sure that service line reporting and patient level costing was one of the kind of central sources of information for financial management. We were going through the costing transformation program, and we could see the kind of the benefits of that information and how it was a really powerful source of information for boards to make decisions, for operational management to look at clinical variation, look at cost opportunities, look at value improvements, and ultimately like the quality of patient care and improving that, which is ultimately why we all work for the NHS. So that was our vision. And this is just a little bit about our journey. So that it was set up for kind of 2020 to 2025, which we've now hit. Things changed along the way, as we'll go into, but kind of this is where we started as like 3 separate systems. We implemented SLR and a merged PLIX model. We were busy doing merger planning, having one ledger, all the corporate services restructured, all the operational, everything restructured basically. We moved offices, but all while we were doing that, we were submitting our PLIX as one. We managed to do that. We supported cost improvement planning, and ultimately the goal was to be best in class. And in 2023, at the HMA conference, we got an award. So I think we in some ways achieved that. So we were quite proud of that. And one of the main projects that was on that submission and that award was the fracture liaison service. And Rachel's going to tell you a little bit about that as we go through. So some way into that 5-year plan, the national emergence of system working came to the forefront, and ICBs were born in 2022. With that, we started to see some sharing of our senior leadership positions. So our finance director was also very much part of the ICB, and our very own head of costing and benchmarking expanded her role to head up costing at the ICB as well. And then that's when Rachel and another colleague kind of joined our team. We started working more closely together. So following the establishment of the ICB, the model that we had been kind of setting up as MSCFT was extended to incorporate the acute mental health and community services into a system-wide costing hub. So the hub is made up of 4 teams. Is that everybody? No, there's another one. So there's us, there's the ICB, and there's also EPUT and NELFT, who are our community and mental health colleagues. And we also got a community collaborative who provide some of our community care as well. So far, it's mainly been the acute trust and MSCFT working closely together. But the strategic plan, and once we're getting a new EPR system and undertaking SLR for the system, and the plan is to sort of work more closely together as we go through. So, and that's the hub members, that's the kind of strategic direction. We've had a couple of away days where members of all the teams have joined us, but it's slow going, and there's obviously the day job is always there. So what's new about what we do? So we're still doing all that usual work. We're all still supporting our operational colleagues, and preparing the models and everything like that. But we also now support the stewardship program. Again, I won't touch on that too much now because we'll expand on that as we go through. And the patient pathway redesign team, which kind of does what it says on the tin. We have been supporting ICB business cases, leading on the development of system patient pathway costing. And we've been working together to develop that 5-year costing strategy. So there's a lot of extra audiences that we're linking in with, and promoting the use of available resources and helping colleagues to navigate and understand what's there, how to use it, in kind of all those different forums. So the vision that we had from the trust point of view, we extended that. We had our first away day in 2023 and a second last autumn, and we established a baseline position to start to develop a strategy for the whole system hub. It was identified that all organisations had kind of good data availability and quality. We had some good costing systems and the right levels of resources and training internally. So the next was to work out where we wanted to go with the hub, and that's centred around expanding our clinical leadership and engagement, education and training on costing data for clinical and operational staff, and then further developing a patient pathway costing to support system service line reporting. And also the hope was we could look at some like system level kind of engagement value outcome, those EVO projects. So we looked at kind of all our different stakeholders and what they'd want out of the information that we were providing, to make sure that we were going to be adding value and providing something that was of real use to people. So what have we achieved so far? We're the first system in the country to establish a costing hub, to our knowledge. If anyone else out there is doing this and want to share experiences and tips and tricks, then please do contact us and let us know. We presented at the HFMA National Costing for Value Institute conference and also London Costing Forum. And we have written up our approach to system costing as a case study for others to follow. I think that's available online. ICB costing staff have completed the cost training program that we developed in MSCFT. When they joined us, they were new to costing. So that gave them a good insight into what we've been doing at the trust, and all the different resources and principles and everything like that we'd included in that pack. We set up a Teams channel for all the costing teams across the ICS to come together and collaborate. So there's a place that we can share files and talk easily. As I say, we've held 2 system costing hub away days so far and starting to shape that 5-year strategy for our stakeholders. We've also developed an ICB model health system training pack, and that's been delivered to the pathway development team to help them understand kind of what's available in model health system and how to use it. We've also been supporting stewardship groups. This is coming in a weird order. We've taken our first steps into developing system pathway costing, and Rachel will tell you more about that. We're at the start of it. There's a long way to go, but the hope is that will support pathway redesign. We've contributed to the acute trust efficiency schemes and GERFT using model hospital system data and also internal MSCFT costing information. So we've developed a number of dashboards to help people. We've been building system SLR, and that includes working with AGEM and the ICB digital team on digital solutions. That's to make sure that we can get that out to people so people can begin to use it. We've worked with the Stroke Stewardship Group on the STAR project involving activity and cost information on stroke interventions, and that's supported moving the stroke stewardship programme forwards, and they're looking at dashboards and things as well now. And we've also developed Power BI dashboards at both MSCFT and in the ICB. And MSCFT have also moved our costing system onto a cloud platform. So the potential being that quite far into the future, all the costing systems would be able to move onto that platform and use all the same dashboards and access all the information once you've got past any information governance.
Right.
Yeah. So bringing that on to the difficulties and challenges. There's no blueprint to follow. So what we're trying to achieve doesn't have kind of clear guidelines to follow. So we're learning as we go. And as I just alluded to, those information governance restrictions, I'm sure everyone's come up against those. What we can share, how we can share it, is all subject to rules and regs, which are there for a reason. The sharing of patient level information is always a touchy subject that has to be, you have to train, and that's how the patient level information is fortunately how everything matches up. So working through that is quite a minefield. The technology also differs across the different organisations. So some of us have access to Power BI, some don't. And the platforms that we access that on are slightly different as well, and managed differently through different third parties and stuff like that. The federated data platform, if anyone's come across that or doing anything on it, please let us know. This development, it's been quite a recent one, has kind of stuttered our progress. We at our second away day, we were starting to think about how we can build a platform to sort of host all of our information from the costing models, so we could start to kind of link that up and do that. But the emergence of the FDP has kind of stalled us on that, because it's kind of a similar tool, and that's kind of the idea of it, that NHSE are kind of developing that. So what we've done, we weren't sure whether that would be duplicated effort, contradictory, so that's kind of stopped for the moment, whilst we work out what's going on with the FDP. And there's also, because that's happening, a lot of the resources in healthcare analytics and digital are concentrated on that rather than anything that we'd like to do. The ICB restructured for a second time in a matter of months, it seemed, I'm sure, for Rachel. This meant the stewardship programme stalled a bit as well, and there were changes in leadership and the support available to do those things. So that was a little bit of a barrier as well. We are also embarking on a new EPR, again a first of its kind, cross-organisational electronic patient record. The hope is that this will encompass the acute trust's 3 current systems. So currently we've got 1 per site, and EPUT has 7 systems. So that is due to go live in 2026, and that's currently in implementation. We had a meeting earlier today, actually, with our healthcare analytics colleagues, and that's all kind of really kicking off from February. So he'll be preoccupied with getting that all together, and the amount of systems that input and go into those, that boil down to that 3 and 7, there's quite a list of different systems. We are also financially challenged as a system and definitely as a trust. So that brings with it its own challenges, and the ask is constantly trying to service that and trying to find cost improvements, and work with our operational colleagues to look for clinical variation, look for improvements that can be made to productivity and quality and cost and resource use. Sort of takes all the time up, and new developments kind of go on the back burner while you kind of do that. Block contract arrangements is another area that's kind of been fun to try and navigate, because block contracts rather than cost and volume arrangements have been in place. That kind of it's kind of been a detriment to our accounting and coding, and how that's all done, and then unpicking that to try and reconcile between what the ICB's got and what the trust has got and things like that is all a tricky one to navigate. And then that leads into I think we've been quite a bit over ambitious with the resources we have available. We are a small team. There's 6 of us at the acute trust, 2 in the ICB, and there's been they're quite small teams at EPUT and NELFT as well, and there's been changes in personnel too. So what we want to do versus what we physically can do, there's a gap there. And including all the cuts to serve all the different stakeholders. What we'd like to do is be able to cut the data to be able to report that kind of the preventative healthcare, the treatment programs, and the end of life, which supports the regional vision. But as Rachel will tell you later, kind of trying to look at how everything's recorded and how we can match things up across the different organisations is challenging, because lots of different things slot into different and overlap when you think about like diabetes care and things like that, or frailty. They all touch lots of different areas, and trying to kind of map all that out is interesting. And finally, just needs a shift in culture, thinking about the system pound rather than in silos as separate organisations, and looking to make kind of, it's not profit in NHS, but trying to look after your own. It was always the way things were done. So thinking about things as a system and getting the best value for that system pound is a definite culture shift. And not that easy. So it's trying to explain cost versus tariff to colleagues, and just there's lots and lots of information out there. So introducing operational colleagues to all that information has been very much our team's role, and helping them navigate all that, because there's obviously lots of kind of differences in that, how that's looked at, how that's interpreted, and making sure people know what they're looking at, know that they're looking at different time periods, perhaps different cuts to the same data. It can be tricky, and on top of everything else that everyone's trying to do as well. So after pressing you with all those challenges, I will, I think now hand over to Rachel, who's going to take you through some of the particular parts of the project that we're quite proud of.
Hello, so Mid and South Essex ICS has created a stewardship programme to support, is the, no, it's still there.
Sorry, press the wrong button.
A stewardship programme to support clinicians in redesigning the coordination and delivery of care across system partner organisations and care settings. Each group is clinician-led and includes representatives from all ICS providers, encompassing relevant staff groups such as costing and benchmarking. Some of the stewardship groups that have been formed include cancer care, stroke care, ophthalmology, ageing well, mental health and learning disabilities. Each stewardship group is provided with a data pack by the Insight and Evaluation team, with the Costing Hub team supplying benchmarking, costing and activity information. Next slide, please. Next slide, I think. So stewardship is multi-professional, multi-organisational, includes frontline teams working together to get the best out of our health, care and resources. Next slide, please. This is an example of the benchmarking work done for one of the stewardship teams, the ophthalmology team. So according to NHS England's national average costs, the cost for Mid and South Essex Trust's ophthalmology activity in a day case setting was higher than the national average. This gave us a cost saving opportunity, as you can see in the top graph. Further analysis was undertaken to understand why. So using the IQVIA Healthcare Optimisation benchmarking tool was used to analyse consultant activity and productivity. It identified the consultants who were the most productive down to the ones who were the least productive, and with the hopes that the most productive are then able to share their best practice. High drug analysis identified that Mid and South Essex was already using the most cost-effective drugs in ophthalmology. An analysis of out-of-area activity revealed that several outpatient procedures could be repatriated back to the trust, therefore reducing additional MFF costs of using London hospitals. Next slide. So the final part of the analysis was theatre activity and productivity. So using Model Hospital, we benchmarked theatre activity against peers, which revealed that there's a capacity to treat more patients and improve productivity. The IQVIA HOB tool found that theatre costs were higher than those of peers, despite having a similar case mix. Each of the trust theatres were compared, and it was found there was a wide variation of costs for the same providers. And we're finding that this is a bit of a legacy of the merger of the three trusts, but it's a relatively easy problem to fix, as we can just share the best practice across the three sites. So using all of the analysis, the stewardship team were able to quickly identify where changes could be made to enable improved value for money and improve patient outcomes. Next slide. To enable pathway redesign, it's essential that the financial resources used across all providers and the stages of the pathway are quantified. The Hub team has developed a methodology to map and cost pathways, which can be seen in this model. And this model is of a pathway prior to transformation. Once the mapping is complete, average costs are used to calculate service costs across the system. This facilitates modelling of movement of activity from one care provider to another, so that those involved can see how proposed changes impact on pathway costs. Once the new pathway has been decided upon, it can be costed in the same way as the original pathway for comparison and using procurement of redesigned services if needed. We've found that quantifying financial resources and mapping pathways can significantly improve service delivery by identifying inefficiencies, so pinpointing areas where resources are not optimally used, and cost management, allowing for better budgeting and cost control across the system, informed decision making, providing data to support decisions on shifting activity between providers, enhanced coordination, facilitating smoother transitions and coordination between different stages of care, and finally improved outcomes, ultimately, which lead to more efficient and effective patient care. So this redesign was a cross-system collaboration to create a fracture liaison service. The aim was to ensure that individuals over 50 who are at risk of osteoporosis receive a comprehensive assessment and personalised care plan. Clinical evidence shows that early identification of osteoporosis and treatment via osteoporosis medication reduces the risk of future fractures by 30 to 40%. So fracture of the neck of the femur is one of the most common reasons for non-elective admissions and has one of the highest length of stays and the highest costs at the trust. Additionally, the wider consequences include reduced mobility, which in turn increases social care and community nursing costs. The system-wide team developed a new fracture liaison service, which has the potential to prevent approximately a quarter of hip fractures a year across the system and a saving of approximately £5 million annually, which is related to the acute phase of care. Further savings are expected as a result of eliminating post-discharge community service contracts and rehabilitation. The intention is for the ICB to use these savings to fund further preventative healthcare programmes. The clarity on the cost base of pathways, which was provided by the Hub team, has been fundamental in supporting this service redesign and ensuring system resources can be allocated more appropriately. This is increasingly expected to be seen as stewardship groups are embedded across the ICS. The Fracture Liaison Service was featured in September 2023 in the Sunday Express as part of its Better Bones campaign. It was featured in a workshop at the 2023 Royal Osteoporosis Society Conference and was also mentioned in Parliament in that same year in a question for a short debate in which MSc ICS funding approval was mentioned. So just over a year on since the service started to be implemented, it already appears to be having some impact, as can be seen in the graph. However, more investigation is being undertaken to clarify if the service is the sole cause of this reduction or not. Next slide. Since the Costing Hub was created, there has been 2 ICB procurements for new providers. Using actual costs and costing methodologies, we can accurately show proposed savings to better utilise system funds. Accurate costing is crucial because it ensures financial efficiency, supports decision-making, enhances transparency, improves budgeting, identifies savings, and it justifies investments, providing evidence to support funding requests and investments in new services or improvements. Previously, as Emma mentioned, the ICB teams involved in procuring new providers would have used the national tariff to cost up any new business cases. However, this doesn't demonstrate the actual cost, and any proposed savings would be negligible if fixed costs and overheads haven't been included. Due to the success of the involvement of the Costing Hub in these ICB procurement projects, we've been invited to assist with future procurements. The next slide. Since the formation of the System Costing Hub team, we've been actively benchmarking service costs against our peers for stewardship and other colleagues. Previously, this task was solely handled by the Trust Costing and Benchmarking team. However, with the inclusion of the ICB team into the Costing Hub, we can now share this information with a broader audience. By combining performance and costing benchmarking, we can pinpoint areas where clinicians and others can make service improvements. These enhancements lead to a greater efficiency for both the hospital and ultimately the patients. It's a culture shift and a new way of thinking about productivity and effective use of the system pound to deliver quality healthcare and outcomes for patients. So the next step is setting up system costing SLR. Service line reporting is well established among system providers, but it's rarely been implemented for ICBs or CCGs, except for maybe the annual programme budgeting, which was resource intensive and possibly not overly suitable for today's ICBs. The aims of SLR reporting are to understand spending at each service level and facilitate future service redesign, ultimately leading to more efficient resource allocation and improved patient outcomes. Originally, we planned to assign each provider to a stewardship group, but this was intangible. Instead, we've assigned national specialty codes to each provider to accurately reflect their services. Where providers have multiple services, such as acute hospitals, mental health, community service providers, we've used a percentage allocation based on their actuals. We aim to implement costing methodologies to allocate ICB overheads to each services, including we obtain a true cost. Initially, we're considering all provider spending as cost to the ICB. The next step is to replace the spending of the two system providers with their actual costs to determine the true cost to the system. The tool will initially be used by finance colleagues and later by wider ICB and then ICS colleagues for future service redesign and monitoring. I'll hand you back to Emma.
So just our next steps. So we've got an idea of where we want to go, but we're still developing a 5-year costing strategy for the system hub to support the delivery of system objectives. We plan to develop and deliver presentations to the stewardship groups and continue our work with them, and also with other stakeholder groups to give them greater understanding of how we can support them and in turn improve clinical engagement in PLICs. And we are going to continue to develop that system patient pathway costing and bring in all the different aspects to get to that one true view of that system pound. We've done quite a lot of work at the trust in participating in NHS benchmarking networks programme of studies over the last couple of years, and we've very much improved how much we were submitting data for that, and also using that data to make operational decisions. The plan is to kind of expand that to the other organisations in the system as well. There's a lot of system work that they do, and I think it'd be really powerful and useful to use that going forward. We also would really like to set up a programme of EVO projects at the trust and then widen that scope to system pathways. That's with everything else that's been going on in the world of the trust and the system and challenges. That's been difficult to get off the ground, but we still have got that in our sights, and we would really like to develop that. And that's us. Thank you for listening. And if anyone has any questions, we'll do our best to answer anything anyone's got.
Thank you both. If anyone has any questions, please just raise your hand or put them in the chat, or you can email them over to me and I can pass them on a bit later.